Welcome to Listen to This, the podcast examining how we can improve the quality and safety of healthcare. This series explored current and long-standing healthcare challenges and discussed some of the work that's being done to address them. In this episode, we revisit some of the key points and discuss the insights shared throughout the series. I'm Graham Martin, and I'm joined by my series co-host, Tara Lamont, who has advised on the Institute's fellowship programme. So Tara, we've had a really interesting series, I think 7 episodes. You were the host of 3 of them. Tell me, what are your biggest highlights? What are the big take-homes for you from the series?
It was great listening to all 7 episodes. I guess one of my big take-homes was just the richness of the kind of diverse backgrounds and expertise of the participants, and I guess beautifully illustrating what healthcare improvement needs in terms of a combination of very different disciplines and traditions. So we had established health service researchers with architects, engineers, designers, data scientists. Just in one episode, civil engineer, a data scientist, a designer, another episode, a kind of clinical researcher in critical care, a paramedic, an anthropologist. And it was fascinating to see how these different projects really had some sort of synergy and some common themes across. Were you finding that?
Yeah, they all had something to talk about, didn't they? And some of those convergences you could have predicted, but others, took them by surprise, and certainly me by surprise. I think in the final episode, the one you mentioned that included Karanan, it included Niels, and it included Graham Pullen, you couldn't really think of 3 more different disciplinary backgrounds, but they all really articulated what they could give to healthcare improvement studies. And they also saw really interesting opportunities in each other's disciplines as well, I thought. So Niels, as a data scientist, speaking about Karanan's background from a sort of operations and facilities, research on waste. And then Graham, posing that challenge and saying, I think disruptor was the word he used in terms of the perspective that he brings, design, creativity, and how that can really open things up that you wouldn't necessarily... they wouldn't be on your horizon, I suppose. You wouldn't think that they were going to be relevant to the study of improvement.
And in fact, they all 3 talked about to their position and being in that sort of hybrid field, how it can be quite difficult because, they're all we're still very siloed in the fields of research and in the fields of clinical improvement. And if you step outside that, I think Niels made that point, you need to extend the boundaries of whatever discipline, but it can also be quite a lonely and exposed space. So I think there was something there. And I agree with you about those insights which seemed to, happen as they were speaking. So I'm thinking about the first episode, which was around access to healthcare. And you've got Sean Manzi with a systems modelling approach, tracking patients with inpatient eating disorders. And I suppose just that's another theme that came out to me about the importance of looking at whole systems and the complexity. So in trying to solve one problem, and Georgia Black, from a qualitative look at cancer pathways and new pathways, saying how in trying to solve one problem, we might create another problem in different sectors and settings. And in that episode, they were joined by a researcher, Patrick Birch, who's a GP looking at extended access hub. So again, a solution to solve the problem of demand on GPs, but then you get issues around continuity of care and challenges, which again, some of that qualitative research was able to pick up from the patient experience point of view.
Yeah, and I think one of the things that really brought the series together for me was the way it highlighted things that I'm very aware of in the abstract, in, dare I say it, from an academic perspective. So we know that healthcare is facing unprecedented pressures. We know that multimorbidity poses challenges. We know that, the response the healthcare system has to embrace to ensure that it gives high quality care in that kind of situation is different from what went before in terms of multidisciplinarity, team working, and so on. But there was something about the way that each of the individual fellows, but also each of the episodes concretized that really brought it to life for me. So, the episode, as you say, on primary care pressures. Similarly, the episode looking at intensive care, and the one on how to do less in healthcare and all the misaligned incentives that can give rise to that. I suppose, this brought home to me things that I'm really aware of in general terms, but it showed how they manifest in different ways in different places. So, for example, Heather Cassie talking about the evidence base around actually we should be doing probably a good deal less in dental care. Yeah. Similarly, Claire Hastings talking about how you can reduce activity or non-value adding activity in primary care. All of these things are things I know about, but then you hear why it doesn't happen in practice. And again, at the abstract level, why it doesn't happen in practice. Incentives misaligned, embedded forms of behaviour and so on. But actually, you hear it's about the interactions between those things as well. So, it's all very well that an evidence base says that we should be having fewer routine dental appointments, or that we don't need to send off for as many blood tests. But when you're in the thick of it, and when actually, for example, patients' expectations, service users' expectations, the expectations of policy, legal expectations and legal accountabilities are pushing against that.
Absolutely.
It becomes so much more difficult.
Yeah, and I think that in that episode, it was a really interesting discussion about why is it so hard. And I think it often has been framed around we need to educate staff to order fewer tests or treatments or prescribe antibiotics. We need to educate patients. They're not expecting an antibiotic prescription for a sore throat. But I think what came out in that conversation was how it is, as you said, misaligned incentives and how it's very difficult. And I think, the two other things that came out for me there was one was the value of a lot of our fellows having this rich clinical or service background and bringing that into their research. So I think in that episode we heard from Claire Hastings, who's a paramedic by background, and bringing some of that lived experience of how difficult it is not to convey patients when they and their family think that going to hospital is being taken seriously, and the reassurance factor. And the other thing that came out in that episode, I think, was the time needed to make shared decision making a reality. So to achieve doing less, you need to spend longer with patients going through why a watch and wait might be the best outcome. And I think that brings me to another really key take home from across a number of these episodes was the value of qualitative and observational research in exposing some of the hidden work, particularly the relational work that's needed to make services and systems work. And that came out very strongly in the episode on doing less, but also in the episode on relationships and rituals in multidisciplinary teams. So Sarah Yardley has this wonderful phrase of the relational glue and the coordinating the ripples of contacts and influence that are needed, the work that is needed by individual staff, in her case looking at serious mental illness and palliative care, to bridge the gaps between sectors and teams and systems. Again, bringing her own lived experience as an end-of-life care doctor to her very important research.
And again, it's something that in the abstract or in general is obvious. Of course, we need strong relationships. Of course, we need to put these things into place. But again, there was something about the way that the fellows and the other contributors to the podcast brought it to life. So, for example, in order to be ready to work as a team when something goes wrong, when you're in an emergency department and you're understaffed, or the ED is overflowing, or when you've got to make these compromises, if you're not set up in advance to do that well, because you've done the team building, all the stuff that Janelle mentioned in that episode, for example, then you're just not going to be well positioned to respond optimally for it and to make those trade-offs in a mindful, conscious, explicit way. You're just improvising, as Charles Vincent would put it, rather than really coordinating in compromised circumstances.
Yeah, and all that work. And again, in that episode, Justin Waring talking about the new perioperative pathway for frail older people, and how, the introduction of geriatricians in what was a kind of surgical domain, the work needed. I think he talked about the negotiating work needed to kind of span those boundaries. And again, it's not something, I think, in improvement work, in transformative service change, we think about structures and policies, but not about the kind of relationship building and the time taken and needed to do that well.
Absolutely. And again, another uniting theme across the episodes, the diversity of viewpoints that are valuable there.
Yes.
And again,
that came out in your episode, didn't it?
Both of them, I think. Yeah. I was thinking also, I suppose partly of that episode, also the episode on intensive care. So when Debbie Clark and Joe McPeak were discussing COVID and the pressures that were present in intensive care at that time, and particularly how it disrupted some of the relationships that they'd really taken for granted. So, intensive care being an unusual situation since patients are often unconscious. During COVID, they couldn't connect with families in the same way. And of course, that's not great from knowing the point of view of knowing the patient and knowing what they would want and knowing what they need. But it also disrupts, in a much more practical sense, the day-to-day work of the hospital. And, Joe, for example, was talking about something that was, just never really struck me before. Of course, we think that involving patients and families is good from a values point of view. It's what we should be doing, but also it's vital to the smoothness of the operation of healthcare. So, good discharge planning. If you don't know what the setup is at home via the patient and or their informal carers and the family, then, the evidence shows, as Joe was able to articulate, that discharge planning is going to be less effective. So it's doing it because it's the right thing, but it's also doing it because it turns out that these relationships, this dispersed knowledge across different groups is really, really vital to good care, to good research as well. That makes me think of the episode on co-design where Michelle Peter was talking about the work she'd done with Black African and Black Caribbean communities around prenatal screening, and how it actually opened her eyes to aspects of that she simply wasn't aware of. Premarital screening, people basically, trying to find out whether they were genetically compatible, or whether, if they had a child together, there would be a high risk of sickle cell disorder. Something that she'd not come across. It was therefore able to inform her research, and at the same time, she had important knowledge to share with them in terms of genetic inheritance and what the risks are. But again, it really points for me towards the functional side of this, the pragmatic and the basic need to bring these points of view together, not just because we should be doing, because actually outcomes of research, outcomes of practice are so much worse if we don't.
And I mean, in that episode too, I thought Ollie Williams' point about sort of managing conflict and tension between stakeholders, and then Nicola Boydell also, it's not obvious in her work on sexual reproductive health, and particularly abortion services, who the sort of patient, as it were, stakeholder is. It's
the person who hasn't yet had to use an abortion service as much as the people who've got direct experience of it. And the sense too of how, I think another common theme in that episode was how to engage in either services or care groups who are stigmatised in some way, and the challenges of that, and some really great insights from those projects. Were there any other big take-homes for you, Graham, around themes or insights that you hadn't Yeah, so one of the things that I suppose surprised me a little bit, or at least in terms of the way it came out, and only came out in a few of the episodes, was the issue of equity and some of the challenges to that. And we typically think about that in terms of demands and how some patients might find access to healthcare more easy than others, or perhaps, we have terms like worried well or pushy patients, that kind of thing. But I suppose what struck me as possibly even more problematic than that in terms of ensuring equity is the rising awareness among patients, service users, the public, of the pressures on the healthcare system, and the way that that is affecting, what people do and don't ask for, and almost people, compensating in advance for the fact that the healthcare system is so pressured in a way that is potentially disadvantageous to them individually, but which also can have big implications for equity. So I think that came over in the first episode for me on primary care, and the point that just increasing capacity without thinking about how different groups access that capacity is probably going to perpetuate systematic inequalities. But it came through in later episodes as well. I think the one on doing less in healthcare. People want to avoid undue pressures on healthcare systems. And so, in terms of the way that you frame those discussions about whether we order this test or not.
Most anticipatory.
Exactly, yeah. So it's less that people are expecting activity. Perhaps the dynamics of those conversations is changing, I think, a bit in terms of it's less about, having to manage expectations downwards and say, we don't want to do this because, overdiagnosis is a thing, and, there are risks associated with this investigation, and it's very unlikely, based on my differential diagnosis, that this is going to be a problem for you. So that's one conversation. But another conversation is actually, well, you are right to come forwards. We don't want to deter you from accessing your GP or accessing the emergency department, for that matter, because you have a risk here that does need to be managed. You are entitled. You are a legitimate, eligible candidate for the healthcare system. So don't suppress those symptoms. And again, that's unequally dispersed. Obviously, the difference between men and women is the classic one, but I think there are social class dimensions to that. There may be ethnicity dimensions to it as well.
No, that's really interesting. And I think equity came up across a number of episodes, both as we were talking about in terms of making the need for researchers to make active steps to engage less heard people in the kind of co-design and engagement episode. But also I think there were some interesting points around equity in relation to sort of quality improvement. So I'm thinking about the episode on learning from failure with James McGowan's work with sort of failing maternity hospitals, where, at a system level, you're focused on perhaps quality ratings and safety ratings, and we're increasingly now, I think, coming back to a sort of targets culture. But what happens to those trusts and hospitals that are caught in a kind of spiral of poor performance, and they tend to be in areas of deprivation, and what does that mean, and do we know enough? I think James McGowan's project saying we don't really focus enough on improving improvement and knowing what works to support those poorly performing organisations.
Yeah, absolutely. We're good at reasonably good at diagnosing, very good at judging, particularly if league tables are making the comeback they appear to be doing. Much less good at knowing the detail of what is needed to improve, but also what works in different circumstances. And I think, one of those key points that James was making was around the fact that what works for a well-performing hospital in a middle-class area that hasn't got a deficit, has got a reasonably stable workforce, doesn't necessarily work for organisations that don't have those advantages. And there's something in there, again, I think it came from the same episode. How do we make that kind of knowledge safe to share? So Helen Crump talking, for example, really about all the disincentives to sharing what's gone wrong as well as what's gone right. Jane O'Hara's very neat term, toxic positivity, and what that can hide. So there's I was talking earlier on about how dispersed this knowledge is. There needs to be more platforms, I think, to bring that knowledge together, to put it in a comprehensible and useful term, and to get it to the right audiences.
I mean, that episode was a lovely illustration of the kind of theme that isn't really addressed, except in that sort of very applied, pragmatic healthcare improvement space. And there's a lot of learning from both kind of failed innovations, as it were, but there's still a lot of positivity bias,
yes,
and
exactly.
we don't have enough extraction of those kinds of examples.
Yeah, and I think again that's another common theme from the series for me, is how these individual, organisation, system level incentives and drivers are often quite ill aligned.
Yeah, so, it's a really striking point, isn't
asking people to prescribe less, for example, when if they get it wrong, all the accountability rests on them. Tensions between things like the sepsis 6. I think this was another of Jane O'Hara's points, versus the need to manage antimicrobial resistance. It feels at times like the system is putting all the onus on the individual, and sometimes putting them in impossible situations.
Yeah.
Whereas actually what we need to do is create systems that support professional judgment, support it with good evidence, but also give people space to make patient-centred individual decisions that are right in the moment. I think
that's where, I had that as a key theme, actually, the trade-offs and tensions, and projects like Debbie Clark's on workarounds. When is it safe not to stick to best practice guidelines? But I was also struck by, I think in the episode on relationships and rituals, Sarah Yardley talking about the district nurse going to give a complex wound dressing, not in the best way, but it was the only way the patient would tolerate.
Yes.
But, knowing that they wouldn't necessarily be backed up if that was the best of the least worst approach for that patient. So I think you're right. It's too much, and particularly with the kind of zero harm, which is a great mantra, but it does mean the pressure on the individuals, and whether they're able to kind of use discretion. But also like these big system trade-offs. I mean, very good point that Jane made about, sepsis 6 versus antimicrobial resistance. But the other one that comes through with some of our projects is the drive towards sustainable healthcare versus infection control. So if you've got a culture, and particularly heightened since COVID, of single-use devices and a kind of throwaway culture in the interest of infection control, how does that square with a greener NHS?
Yeah, some of these debates feel quite long-standing, but there's something new around them. And I mean, in terms of that tension between individual judgment in circumstances that can never quite be predicted and are always slightly different, versus standardization versus evidence-based practice. You've got to find ways to bring those together in imperfect but context-sensitive ways. And it just felt like at times the system didn't allow this to happen. So it feels to me like that's a really important target for improvement research, is how to create systems that reconcile those conflicting expectations, those conflicting requirements, imperatives, and take a little bit off the shoulders of the individual clinician when so much just seems to rest on them right now.
Absolutely. Did you feel from the episodes overall, were there any gaps or directions for future improvement? I mean, I don't have any any very clear agenda, but I was very struck in the episode on the sort of interdisciplinary contributions of there are whole areas like estates and the built environment. When Karanam was talking, I was thinking, have we done enough about looking at the improvement challenges? We focus so much on clinical care and processes, but there's this whole area too around the built environment. There's also the point that Graham Pullen made in that episode about we bring design in at the end to kind of fine-tune solutions. But what about bringing in design sensibilities early on when we're thinking about large-scale service change or...
Yeah, I suppose one of the messages I took home from that episode was just to be conscious of like the boundaries of my own knowledge and accept that I don't know what I don't know, and actually it probably takes someone else to reveal that to me, you know, whether it's Graham on design or Karanan on operations and facilities. I think I suppose there are a couple of, you know, frontiers, if you like, that seem to come out through some of the episodes. So I think one of them is around the backstage, the back office stuff, as well as the clinician-patient interaction stuff. Because, you know, as Karanan and others made clear, and people like James's contribution as well made clear, all of the things that happen behind the scenes are actually crucial to well-functioning healthcare systems, but also crucial to, you know, smooth patient experiences, the continuity of care, outcomes, all the rest of it. And like you say, you know, a lot of improvement research has not unreasonably, quite understandably focused on the front stage stuff that involves clinicians and patients. But, you know, I think it's probably to the credit of the fellowship program that a lot of it has taken a wider perspective, you know, Karan's work and many others. And I think that back office stuff is going to be even more important as we, you know, move into, you know, an era of the NHS and of healthcare systems globally, where there might be extra money in some circumstances, but it's going to come with strings attached. You know, there's going to be pressures around reform, productivity, and so on. And, you know, a lot of that behind the scenes stuff is probably, you know, there's opportunities at least there for improvement that, you know, A, will free up resources for patient and service user facing care, but B, will actually have more direct impacts on that as well. So I think that's one area. Another area, and this came from the co-design episode, was around the constituencies that we see, or the audiences, if you like, that we see as being relevant to healthcare improvement research and healthcare improvement practice. And I think, again, Nicola, Ollie, Michelle, in different ways, they all showed the advantage of speaking to very, very diverse people, as I said earlier on, in terms of the mutual knowledge exchange and learning from them and sharing insights with them, but also the way we define those groups. So as you were saying earlier on, it's not just people who have used abortion services that will have a really important perspective on it, but people who, well, I think as Nicola was saying, people who never anticipate having to use them, but we need their insights as well. It's communities, not just patients narrowly defined, as Michelle was saying, you know, church groups, community groups, all of these wider audiences have a really important perspective on improving healthcare quality, safety, patient experience. But they're also, and this was Ollie's point, I think, really vital as part of a coalition for change, because power doesn't all rest in the NHS, power doesn't all rest in the ivory towers of academia. People coming into co-production activities, co-design activities might perceive it that way. But Ollie's point was that that power is dispersed, and actually one research project ain't going to change the world. One improvement project ain't going to change the world. But it forms part of a platform, and with those alliances across, you know, multiple interest groups, multiple communities, that's how actually longer term change and longer term improvement can be achieved.
Another area where it feels like we're only starting to see the benefits of this kind of analysis or research is, you know, we were talking earlier about these systems-based approaches, and, you know, the kind of work Sean Manzi was doing, saying that, you know, they didn't realise until he did his kind of data linkage across primary, secondary, voluntary sector too, as you say, as coalition of and specialist centres, that actually people in Somerset were perhaps using 70 different eating disorder services which hadn't been rationalised or streamlined, and how you can combine that kind of analytics and modelling with the kind of qualitative insights from the kind of tracking of patient experience, the work needed by staff to navigate these imperfect, broken systems. Yeah,
these pathways that look completely different in practice from what we thought they looked like in principle. And again, that shouldn't be a surprise, but it always is a little bit surprising, isn't it, when it turns out that things are quite so distant from what they, in theory, look like. You know, the work is imagined versus the work is done. And I think, there's definitely something, I think this came out in several episodes about, learning from the day-to-day, understanding the day-to-day, all that safety 2 mentality about,
what goes right.
How safety is reproduced in practice, but how care pathways are reproduced in practice. Yeah. Partly because, you've got to understand that reality to improve it. And partly because actually the ideas for improvement might come from that reality. The workarounds, what constitutes a safe workaround, what good team working under pressure looks like versus ill-coordinated improvisation. So Tara, we're starting to run out of time, but I wonder if you've got any final reflections coming out of the series.
I was just struck by a point that Neil's made in an episode around the fact that he would now call himself a data scientist, but it wasn't a field that existed when he was training. So I wonder what the disciplines and fields of knowledge are to come that will help us shape the quality and safety of healthcare in 20 years' time. We've got AI not just on the horizon, but in place. But there are all sorts of new forms of critical inquiry, and just hearing the range of fellows and participants from the episodes, I feel we won't be short of good minds applying themselves to the enduring problems and complexities of healthcare.
Yeah. And I don't want to curse it, but it does feel like however much AI advances, we will probably still need those good minds, because there's so much that is, complex, that requires, kind of creativity, imagination, insight into the human reality of those things. But I agree, I think AI, big data, all of that kind of thing brings huge possible analytical opportunities. But really, to make sense of them, this comes home from all the episodes, you need that experiential knowledge, whether it derives from clinical work, whether it derives from being a patient. You need the insights and the advantages that a really solid disciplinary grounding brings to you. So a huge thank you to all our guests this series. I've been your host, Graham Martin, and I hope you've enjoyed listening to Listen to This. To find out more about the Institute's latest research, go to our website and head to the podcast page for show notes and to hear the series in full. It's all at thisinstitute.cam.ac.uk. That's thisinstitute, all one word, .cam.ac.uk.